طيب السلام عليكم كلكم جميعا، رحب فيكم في آخر presentation إن شاء الله في ال Pediatric week. We will talk about endocrinology and some growth disorders. إن شاء الله حيكون presentation خفيف نستمتع فيه أنا وياك. طيب كالعادة حيكون عبارة عن 10 أسئلة. حنتكلم عن كل سؤال. نقرأ السؤال، حأعطيكم فرصة تجاوبوه مدة 45 ثانية إلى دقيقة، وبعد كده حنناقش الحل حق السؤال ونشوف الحل مرة ثانية بعد ما نشرح الكونتنت. طيب let's read the first question. A 4-year-old male patient was brought to the hospital by his parents. They are wondering about some unusual characteristics that appeared on the child. After taking a history and doing a physical examination, the following was observed. He has heart and bleeding problems since birth, malformation of the rib cage bones, short stature, down slanting eyes, ocular hypertelorism, webbed neck, and developmental delays. Which of the following syndrome does he most likely have? Now you have 45 seconds. Please answer. Okay, the answers were most going to the Down syndrome. أغلبكم جاوب Down syndrome. بعدها مارفان، بعدها نونم، بعدها سوت. طيب خلينا نشوف الحين presentation of Noonan syndrome. طبعا overview of Noonan syndrome. Syndrome a condition happened in 1,500 live births. It's an autosomal dominant condition. This patient will have normal karyotype لأن the condition is autosomal. Of course, it occurs in males and females. The main thing المشكلة الرئيسية هنا mutation في الRAS MAP pathway. طبعا several mutation has been identified to result in Noonan syndrome. لكن the most common mutation هي mutation in the PTPN11 gene on chromosome number 2. طيب ايش الكاركترستكس اللي دائما نشوفها في النونان syndrome؟ short stature, facial dysmorphism, ocular hypertelorism, down slanting eyes with a webbed neck, heart disease, especially يعني pulmonary valve stenosis, and delayed intellectual development. Just delayed intellectual development. These people, when they grow up, they retain their intellectuality. طيب. This is a picture showing the features. As we can see, there is ocular hypertelorism. The distance between the two eyes is increased. Here we can see another picture that will show more features of this syndrome. So wide-spaced eyes, hypertelorism, epicanthal folds, excess nuchal skin, oval-shaped, low-set posterior rotors, ears with thick helix. Okay, so now what do you think is the answer? Please write in the chat. Yes, correct. It's the Noonan syndrome. طيب تعالوا نروح للكويستشن الثاني. A 15-year-old female patient came to the hospital with her mother. After taking a history and doing physical examination, the following was observed. Shielded chest, amenorrhea, webbed neck, aortic coarctation, strict gonads, and bicuspid aortic valve. In addition to all of that, the parents say that she had swelling of both hands and feet in the neonatal period. Which of the following syndrome does she most likely have? Please, you have 45 seconds. Answer in the poll. طيب جميل، الأغلب جاوب الإجابة الصحيحة اللي هي تيرنر syndrome. Let's discuss Turner syndrome in a minute. Take a view. طبعا regarding the epidemiology 1 in 2500. الأسباب ليش في عنا Turner syndrome أو ليش هي تصير؟ طبعا there is non-disjunction during meiosis. نشرح هذا الكلام إن شاء الله بالسلايدز الجاية. في عنا one missing 6 chromosome here, so we عندنا ending up with 45 chromosome. The karyotype of this هذول patient will be 45XO, always will be a female phenotype, so we call it Turner syndrome. The life expectancy is reduced by more than 10 years to the 10 years of age. طيب في هنا شيء مهم اللي Turner syndrome is not associated with the maternal age. We will discuss بعدين syndrome that is related and associated with the maternal age. طيب لما نجي عند الdiagnosis طبعا Turner syndrome is the most common cause of primary ovarian insufficiency. طيب ليش هالكلام صار؟ عندنا هنا missing of 1X chromosome. هذا يؤدي إلى نقول under development أو replacement of connective tissue. يعني the germ cells in the ovaries will be replaced by connective tissue. وهذا بيسبب gonadal dysgenesis or what we call it streak gonads. طيب إيش بيصير لما يكون عندنا streak gonads؟ The estrogen and androgen secretion will be low. طبعا in response to that, the follicular stimulating hormone and luteinizing hormone will be high. So this condition we call it hypergonadotropic because of increased FSH and LH, hypogonadism due to decreased estrogen and androgens. طبعا confirmatory test of the Turner syndrome is the karyotyping. طيب regarding the features ايش حنلاقي في patients with Turner syndrome? Web neck, shielded chest, increase the distance between the nipples. We have also cardiovascular abnormalities. طبعا زي ما قلنا gonadal dysgenesis. برضه زي ما شفنا في الكيس lymphedema during neonatal period and nail dysplasia. Please answer in the chat. What do you think now is the answer? بالضبط زي ما الأغلب جاوب it's Turner syndrome. طيب نروح للسؤال الثالث. You are an intern in the pediatric ward. 2 days ago, you have discussed with your supervisor a patient case who has a Down syndrome. Which mechanism leads to the least incident of Down syndrome? You have 45 seconds. Please answer the poll. طيب الانسرز اغلبها راحت للموزايك ترايسومي and the other answers. طيب بنشوف الحين ايش الاجابه الصحيحه. طب خلينا ناخذ نظره على الداون syndrome. طبعا it's the most common one of the things that we have discussed. 1 في 700 لايف بيرث. في الاتيولوجي واللي حنتكلم عنها في التفصيل في السلايد الجاي عندنا 3 mechanisms that will lead to Down syndrome. الkaryotype depending about if it is male or female, so XX plus 21 trisomy, so we have more or an added chromosome to of 21, okay, to the chromosome 21. طيب هنا في شيء مهم جدا انه الداون syndrome its risk increase with the maternal age, especially getting pregnancy after the age of 45. For the life expectancy is more than 50 years. We confirm the diagnosis with the karyotyping. But for the features, في أشياء لازم نركز عليها. البروش فيلد سبوتس، هنلاقي سبوتس في في الآيرس، هايبوثايروديزم، single transverse palmar crease. هذا يعني especially in the both hands, a single transverse palmar in the both hands. And also we can find capitodactyly, brachydactyly, and clindodactyly. طيب الساندل gap also is seen in the patient with Down. طيب نرجع للميكانيزم. للميكانيزم اللي قلنا هنشوف اللي أصلا السؤال هنسأل عليه. طيب عندنا 3 ميكانيزم. أول واحدة it's called يعني full trisomy 21 اللي هي الموست common. طيب this يعني عندنا addition of one chromosome, chromosome number 21 in all cells. طيب السبب في هذا هو meiotic non-disjunction. زي ما شفنا في التيرنر syndrome, the same mechanism here, but the difference is in the number of the chromosome itself. Here in the number 21 and there in the X and Y, X chromosome. طيب ايش اللي بيصير في الميوتيك non dysfunction؟ في فشل في السيبريشن either في الميوسيس 1 أو في الميوسيس 2. So either at this point the separation of chromosome is failing or at this point. طيب ايش الفرق؟ طبعا الموست كومن يصير في الميوسيس 1. طيب الفرق انه في الاخير هنا اذا كان في failure في الميوسيس 2 we are ending up of possibility of one trisomy and 2 normal. لكن اذا كان السيبريشن بدري في او الفيلير تو سيبريشن في الميوسيس 1 ending up with 2 possibilities of trisomy and 2 with monosomy. طيب هذه الموست common mechanism. The second mechanism is called translocation trisomy 21 أو اللي نسميها في الجينيتكس Robertsonian translocation. طيب in Robertsonian translocation إيش اللي بيصير؟ طيب زي ما نشوف هنا في الصورة we have set of acrocentric chromosome to normal chromosome. خلينا اللي يقول هذا chromosome number 21 هذا chromosome number 14 اللي هو الموست كمان. ايش اللي بيصير؟ بيصير breakage وين؟ بين اللونج arm والشورت. they translocate. The short arm here come with this short arm and the long arm here will come with this short arm. So ending up with this picture here. Both short arm going to be lost at the end of the meiosis لأنهم basically does not contain important genetic information. طيب هنا لو تلاحظوا سميناه balanced Robertsonian translocation. ليش قلنا عليه balanced؟ لأنه زي ما ملاحظين we didn't lost any genes يعني long arms of both chromosomes are present موجودات. والlong arms of both chromosome 21 are present. So this is called balanced Robertsonian translocation. And this patient يعني will present normally, phenotypically, will appear normally, normal body. Okay? يعني هنلاقي بس المشكلة موجودة في الكاريوتايبنج. Not where there is no phenotypic expression. طيب وين المشكلة الحين؟ المشكلة في الانهيرتنس. هذه نسميها familial Down syndrome. طيب هذا الشخص اللي عنده balanced Robertsonian translocation هنسميه carrier لأنه ما عنده phenotypic expression. When he married and meet هنشوف هنا normal chromosomes. ايش اللي بيصير؟ هياخذ نسخة من هنا نسخة من هنا من الأب والأم ending up بهذا الشكل. إذا هنا عندنا كم long arm of chromosome 21 3 long arms and 2 long arms of chromosome number 14. إذا في long arm واحد زايد إذا هذا يعني يعطينا إيش Down syndrome trisomy 21. إذا نسميه unbalanced Robertsonian translocation. إذا المشكلة هنا حتكون في الانهيرتنس عشان كده نسميه familial Down syndrome. طيب الثيرد mechanism which is the least incidence due to this mechanism اللي هي الموزاك trisomy 1 to 2% of cases. طيب ايش اللي يصير هنا في الموزاك trisomy؟ طبعا موزاك ليش سميها موزاك؟ لأنه هذا الشخص حيكون عنده خلينا نقول normal cells with 46 chromosome and يعني abnormal cells with 47 chromosome. طيب ايش اللي صار؟ صار non-disjunction بس not in the meiosis, it's in the mitosis after fertilization. طيب البرزنتيشن لهذول الاشخاص حيكون different according to what. اذا لاحظنا هنا عندنا هنا انقسام الخليه after the fertilization بعد التلقيح. اذا كان النون ديسفانكشن حصل بدري في البروسيس، طيب قبل ما يتطور البدي كامل، حيكون النسبه للافكتد سيلز او للسيلز that have trisomy 21 يعني بنسبه اكبر مقارنه اذا حصل النون ديسفانكشن later in life، تمام، او later in the development of the fetus. إذا عندنا هنا variable proportion of trisomic and normal cells depending on the timing of the mitotic error, and we will have a variable phenotypic expression. طيب also يعني حاجات مهمة في الداون syndrome اللي هي heart congenital defect. It's common and the commonest one is the endocardial Cushing defect. يعني 43% of individuals have the endocardial Cushing defect. طيب هذه result in what? In atrioventricular septal defect. زي ما شايفين في الصورة اللي هنا تقريبا كل السبتاي it's defected يعني. Followed by ventricular septal defect, secondum atrial septal defect, trilogy of pilot and isolated defect, patent ductus arteriosus. طيب نرجع للسؤال الحين. So what mechanism leads to the least incident of Down syndrome? Please write in the chat. Okay, it's C. Correct. The most of you get it correct. Let's move to the fourth question. طيب, a neonate female patient came to the hospital with her mother. After taking a history and doing physical examination, the following was observed: low set ears, micronatia, prominent occiput, microcephaly, broad nose, cleft lip and palate, and high palate. Which of the following syndrome does she most likely have? Please answer in the poll. Okay, most of you get it correct. Edwards syndrome. Let's take an overview of Edwards syndrome. It's a trisomy of chromosome number 18. Its incidence 1 in 6,000. It's more in the female gender. It's also يعني برضه إذا الداون syndrome والإدوارد syndrome اثنينهم خلينا نقول linked with the maternal age. The life expectancy is only 5 to 10% of the patient survive plus 1 month of age. طبعا we confirm the diagnosis with the karyotyping. لكن نقدر to predict يعني there is Edwards syndrome or not while the patient while in pregnancy during the pregnancy by doing the quadruple test. We will find a decrease in the free estriol, decrease in the alpha fetoprotein, decrease in the inhibin A, and decrease in the beta HCG. طيب الأشياء المهمة خلينا نقول في presentation: clenched fist with flexion contraction of the fingers, broad nose, cleft lip and palate with high palate, microcephaly, prominent occiput, low set ears, malformed auricles, and micronatia. Now, please answer in the chat. What do you think is the correct answer? Exactly, it's Edwards. Let's move to the fifth question. A pediatric patient presented complaining of weight gain with lack of height gain, high blood pressure, purple stretch markers in the abdomen, hirsutism, impaired glucose tolerance, irritability, and fatigue. What's your initial workup for such patient? Please answer the poll. Most of you get the correct answer. What do you suspect in this case? Can you write in the chat? What do you suspect that this patient has? Exactly, Cushing syndrome. So let's see how the workup of the when we suspecting Cushing syndrome. طيب Cushing syndrome is basically increase in the cortisol. طيب هذا الانكريز ممكن يكون ايش of exogenous source أو endogenous source. So we need to ask نسأل البيشنت أو نشوف الهيستوري إذا في أي prolonged glucocorticoid therapy إذا كان في موجود هذا الشيء إذا it's most likely exogenous Cushing syndrome. طيب إذا ما في أو children there is no exposure to glucocorticoid therapy نروح للscreening test to see is that really an Cushing syndrome or not. طيب we have 3 tests here. We pick any one of them, either 24-hour urine cortisol or low dose dexamethasone suppression test أو midnight silvery أو serum cortisol. طيب اللو دوز ال 24-hour urine cortisol واضح احنا حنشوف كم في الكورتيزول خلال هذا الوقت. المدنات سلبري او سيرم كورتيزول برضه يعني برضه شيء واضح حنشوف الكونتنت اوف كورتيزول. بس اللو دوز ديكساميثاسون سبريشن تيست سميناه لو دوز لانه بعدين حنشوف شيء اسمه هاي دوز. طبعا الدوز in this test is 1 milligram. We give it to the patient at 11 at the night 11 p.m. بعدين we test for the cortisol serum cortisol at the morning at about 8 a.m. طيب if we find it increase this is positive. طبعا if the screening test all of them are negative Cushing syndrome is unlikely and we need to look for other differentiation. Let's assume it is positive. الآن طبعا الكورتيزول as we know السكريشن حيكون after the stimulation by the hormone ACTH secreted by the pituitary. طيب we need to see هل هذا السكريشن أو increase in secretion is due to stimulation by the ACTH or not. We will assess serum ACTH. If it is low, which is the case if the ACTH has no abnormality or the secretion of the ACTH, it will be low because of the negative feedback loop. We call it ACTH independent Cushing syndrome. ندور على إيش؟ على أي autonomous overproduction of cortisol by the adrenal gland. We can call it a primary Cushing syndrome لأنه جاي من الادرينال gland and it is ACTH independent. In that case هنروح نعمل CT MRI للabdomen to look for any adrenal adenoma, carcinoma or hyperplasia and then we discuss and evaluate for surgery. طيب إذا كان عندنا increase في ال ACTH أو it is normal اللي هو المفروض ما يكون the case لأنه عندنا ارتفاع في الكورتيزول المفروض يكون ال ACTH as we said low. طيب if it is normal or elevated that means it is ACTH dependent Cushing syndrome. هذا ال hyper secretion of cortisol is due to is by the action of the ACTH. طيب ال ACTH ممكن يكون طلع either central اللي هم البيتوتري normal location or ectopic من شيء غير البيتوتري production. كيف نفرق بين الاثنين هذول؟ كيف نقول هذا central or ectopic؟ نسوي الconfirmation test. We have 2 tests here. Either the high dose dexamethasone suppression test أو the CRH stimulation test اللي هو corticotropin releasing hormone stimulation test. طيب both of these either the high dose dexamethasone suppression test أو CRH stimulation test are sensitive for the central Cushing syndrome. يعني they will give a result in case if it was central. لأنه يعني إذا كان central the pituitary gland will respond to the high increase in the dexamethasone أو will respond to the CRH hormone. طيب إذا عملنا أي واحد من هذول dexamethasone suppression of ACTH يعني حصل في suppression أو إذا استخدمنا CRH stimulation test لقينا increase in the ACTH الكورتيزول وال CRH هذا يعني إنه في response من البيتيوتري جلاند للتست هذول. That means إنه الكوشنج syndrome مصدره أو ال ACTH مصدره is central. So we do cranial CT MRI to look for any pituitary adenoma. طبعا if we find a pituitary adenoma we call it Cushing disease and then we evaluate for surgery. But let's say we did one of these tests لكن ما كان في عندنا suppression لل ACTH ولا كان عندنا increase of the ACTH cortisol لما أعطينا CRH. طيب هذا يعني إنه ال ACTH production كان from ectopic gland that is يعني ما عندها negative feedback loop أو it's not sensitive for the dexamethasone أو برضه the CRH يعني is not activating this ectopic gland. فإذا ما في أي response هنقول إنها ectopic ACTH production. بعد هذا بنروح ندور وين هذه الectopic gland. طبعا we suspect some condition that might have secretion of ACTH such as small cell lung cancer, renal cell carcinoma and the carcinoid. وبندور على primary malignancy. Okay, let's come to our question. So what is your initial workup here? Please answer in the chat. Exactly, it's the low dexamethasone suppression test to screen for Cushing syndrome. طيب نروح السؤال اللي بعده. Congenital adrenal hyperplasia is an inherited enzyme defect that impair cortisol synthesis and result in the accumulation of cortisol precursors. What is the mode of inheritance of the CAH? Please answer the poll. You have 40%. Exactly, most of you answered correctly. Autosomal recessive. Let's discuss it in brief. Congenital adrenal hyperplasia. طبعا the aim of the question about the type of inheritance, it is autosomal recessive. عندنا ثلاث أنواع من ال CAH. طبعا according to the enzyme that is affected. It's either 21 beta hydroxylase اللي هو most common أو 11 beta hydroxylase second most common أو 17 alpha hydroxylase اللي هو the rarest form. طبعا each of one of them is involved in the يعني موجود في process of production of the cortisol from cholesterol. طيب خلينا نتكلم عن most common one ال 21 beta hydroxylase اللي هو most common. عندنا منه two types classic and non-classic. الكلاسيك type معانا complete deficiency of this enzyme يعني we don't have cortisol at all. So we're gonna get a signs of no cortisol. طيب النون كلاسيك فورم ممكن يكون عندنا deficiency طبعا ممكن تكون 70% 50% 20% على حسب الشخص فنسميه non classic form. the aim of the question this is يعني about the mode of inheritance اللي هو autosomal recessive. عشان كذا ما حنروح في التفاصيل حق البروسيس انا حضيف ان شاء الله سلايد عشان ممكن ترجعوا التفاصيل اذا حد حاب. اذا نرجع للكويشن could you please write in the chat what do you think is the answer. Yes, correct. It's autosomal recessive. نروح السؤال اللي بعده. A child was admitted to the hospital complaining of polydipsia, polyuria, and persistent thirst with dilute urine. Labs has been done, which showed that plasma osmolality is 320 milliosmol per kilogram, which is high, and urine osmolality is 200 milliosmol per kilogram, which is low. Water deprivation test has been done, but nothing changed regarding labs value. After the administration of desmopressin, urine osmolality had increased to normal levels. What is your diagnosis in such case? Please answer in the poll. You have 45 seconds. طيب, here the answers. Let's say most of you answered SIADA, اللي هي syndrome of inappropriate secretion of the ADH, which is unfortunately it's incorrect. Let's discuss the diabetes insipidus and return back to our question. طيب, diabetes insipidus, it's basically inability to produce concentrated urine as a result of antidiuretic hormone dysfunction. طيب, هذا الدysfunction ممكن يكون على two forms. إما حيكون central أو حيكون nephrogenic. طيب, central يعني حيكون له علاقة بالposterior pituitary gland اللي هو failure of secretion of the ADH. إذا ما عندنا إيش؟ ما عندنا أبدا ADH. طيب, nephrogenic we do have ADH لكن there is a failure to respond to the ADH. طيب كيف حنفرق بينهم? What is the approach? When we suspect diabetes insipidus from the serum osmolality and the urine osmolality, and when we have the urine is dilute, we need to suspect the diabetes insipidus. What we will order, plasma sodium and osmolality and urine osmolality. طيب, إذا كان عندنا hyponatremia, plasma osmolality is low to normal and urine osmolality is very low. We suspect the primary polydipsia, which is basically a psychological cause of drinking too much. طيب, اللي هنا خلانا نفرق يعني why we ليش احنا يعني رحنا للsuspicion of primary polydipsia اللي هي الهايبوناتريميا. طيب, لكن إذا كان عندنا mild hypernatremia أو البلازما osmolality is high to normal, تمام, اليورين osmolality is low اللي هي less than 500, we're gonna suspect diabetes insipidus, which is very likely. But how to confirm? طيب, بنعمل اللي هو water deprivation test. طب ايش يعني water deprivation test؟ هنقطع الماء عن المريض لمدة 2 إلى 3 وبعدين حنعيد اللابس. طيب, إذا البلازما osmolality returned to normal واليورين osmolality returned to normal, يعني هذا الشخص فقط كان يشرب مويه بزيادة, يعني عنده primary polydipsia is most likely. لكن إذا ما لقينا أي result of the water deprivation test, plasma osmolality is still high, اليورين osmolality remains low, we give desmopressin اللي هو basically a synthetic analog of the hormone ADH. طيب, إذا أعطيت desmopressin وكان في response للدesmopressin, that means يعني إنه response of the kidney to the ADH is normal لأنه لقينا هنا في response, يعني the cause is central diabetes insipidus. There is no secretion of the ADH from the pituitary gland. أما إذا ما كان عندنا أي response, اليورين osmolality stays low بعد ما جبنا الدesmopressin, that means يعني المشكلة في response of the kidney of the receptors of the ADH, so it is nephrogenic diabetes insipidus. But let's get back to our question. I will read it again and discuss it with you to see the answers after that. But the child was admitted to the hospital complaining of polydipsia, polyuria, and persistent thirst while dilute urine. This, as we know, it's a sign of diabetes, and polydipsia because this patient does not have ADH. Polyuria does not have PDH. Polydipsia because he is losing a lot of water. And persistent thirst also to the same reason. طيب في اللابس البلازما osmolality كانت high والurine osmolality كانت low. يعني this patient cannot reabsorb water to compensate for this high plasma osmolality. طيب عملوا له water deprivation test لكن nothing changed regarding the lab value. يعني إنه this patient does not have primary polydipsia, so we exclude primary polydipsia. After we administered desmopressin to that patient, urine osmolality increased to normal levels. يعني رجعت to the normal. يعني there was a response for the desmopressin. يعني this is a central diabetes insipidus. Okay, we have a question. May you explain why it is not SIADA? SIADA is the opposite. We have syndrome of inappropriate secretion of ADH. So we will not find plasma osmolality high. لأنه عندنا يعني over reabsorption of water. So it's the opposite condition. Is it clear? Okay. Let's move to the next question. Exactly. Also, SIADA comes with hyponatremia. Okay. The next question. An 18-month-old infant is seen because the mother is concerned that his legs are bowed, as we can see in the photo. The infant was breastfed until 14 months of age. X-ray has been done and showed widening of the ends of the growth plates. Laboratory findings are low calcium, mildly high parathyroid hormone, PTH, and very high alkaline phosphatase, ALP. What does this patient most likely have? Please answer in the poll. You have 45 seconds. Obviously, most of you answered correctly. So the obvious question, let's discuss rickets in brief. So the pathophysiology of rickets, we know it's an improper mineralization of the bone or a defect in the mineralization pathway. Okay. طيب هذه ممكن تصير إذا في حالتين، إما فيتامين دي dependent أو فيتامين دي independent. الفيتامين دي dependent بتكون either due to deficiency أو due to defective vitamin D metabolism. الفيتامين دي independent بتكون دائما due to phosphate deficiency but it's less common. طيب إذا ما في فيتامين دي we will have hypocalcemia. Vitamin D will help in the reabsorption and getting calcium into the blood. What will happen? Defective cartilaginous growth plate mineralization, which is rickets. In the طبعا هنا cartilaginous growth plate mineralization, we call it rickets in children. But if it is in the adult, we call it osteomalacia. It will be defective bone mineralization, not cartilaginous mineralization. طيب إذا عندنا hypocalcemia, as a response to that, parathyroid hormone will increase عشان يطلع يعني to get more calcium in the blood. As a result of increasing the parathyroid hormone, phosphate levels will decrease. Then the parathyroid hormone will increase the reabsorption of calcium from the kidneys and the excretion of the phosphate. طبعا بالأخير ناخذ بيطلع معنا impaired mineralization. طيب impaired mineralization in these individuals, what is the clinical features of that? We will have bone deformities, bending of the primarily the long bones, because يعني زي ما احنا عارفين المينراليزيشن itself it give us the strength for the bones. وما إذا عندنا impaired mineralization يعني those bones are weak, they are more likely to bend. طيب others, distension of the bone cartilage junctions. بيعطينا two signs, the Rickett's rosary and the Marfan sign. هنشوف في الصورة بعدين what are these signs. Craniotabes يعني softening of the skull and deformities of the genital horn. طبعا هذول ال patients will have increased risk of fracture. Harrison groove, I'll show it in the picture also. Late closing fontanelles, impaired growth, and symptoms of hypocalcemia. As we can see in this picture, we have delayed closure of fontanelles, frontal posing, dental hypoplasia, pectus herniatum, swelling in the wrist and ankle joint, especially at the ankle joint. This is called Marfan sign, especially at the medial malleolus. Wide sutures, craniotabes, softening of the skull. The Rickett's rosary, it's basically increase the distance here in the between the bone cartilage junctions. Right? Harrison sulcus. طبعا Harrison sulcus, why is there ليش حصل عندنا شيء اسمه Harrison sulcus؟ أول شيء ال rib cage bone here are weak, and because of the diaphragm and the muscle pulling activity, they will bend inward. وإحنا بنشوف ال Harrison sulcus of the patient. And then bowing of the leg. هنا نقدر نشوف the X-ray, the Rickett's rosary, and the bowing of the long bones with the knee deformity Albaraa. But let's get back to the question. Please answer in the chat. Do you think it's correct? Okay, most of you answered correctly. We have a question, why high alkaline phosphatase? The alkaline phosphatase will be high because of the osteoclast activity. طبعا كل ما الاوستيوكلاست طبعا عندنا high parathyroid hormone. Parathyroid hormone need to get calcium from the bone and will activate the osteoclast. The osteoclast activity will give us will lead يعني to high alkaline phosphatase secretion. Is my answer clear? Okay, let's move to the next question. Okay, this question is a practice for you. Please read the question and answer in the poll. I will give you 1 minute for that. Okay, have you answered correctly? We have discussed that, and when we explained the Down syndrome, it's C, endocardial phenoid defect. But we have here a question, why it is nephrogenic? I think he means the diabetes insipidus. Okay, the next question will be about diabetes insipidus, and I will explain why after you solve this question. So please read the question and then answer in the poll. Okay, 49% guessed correctly. It's a peripheral diabetes insipidus. I see clearly there is a problem with this topic. Let's explain it again. The diabetes insipidus. طيب here I think the problem is from this one. Like water deprivation test has been done and قلنا انه ما في response. يعني this patient does really have diabetes insipidus. طيب desmopressin, خلينا نتخيل desmopressin is an ADH. It's the ADH itself. Okay? It's an analog of ADH. الحين إذا كان في response للديزموبريسين يعني في response للADH. That means يعني الADH ارتبط بالريسبتورز اللي موجودين في وين؟ في الكدنيز ورفع اليورين osmolality. يعني الكدني has no problem. طيب يعني المشكله في البدايه انه ما في secretion اصلا of the ADH. So it's central diabetes insipidus. طيب احنا اعطينا ADH لكن there is no response. That means المشكله في الريسبتورز of the response of the kidneys to the ADH. So we call it nephrogenic diabetes insipidus. نرجع للكويشن هذا. طيب تعال نشوف هنا. Water deprivation test has been done but nothing changed. يعني احنا سوينا exclusion ليش؟ هنا nothing changed. سوينا exclusion للبرايمري بوليدبسيا. طيب بعدين اعطينا ديزموبريسين. اذا عندنا الحين خيارين بعد ما اعطينا ديزموبريسين، اما يكون في ريسبونس للديزموبريسين او ما يكون في ريسبونس او لا. طيب هنا شفنا انه في ريسبونس اليورين اوزمولاريتي هذا انكريز. يعني المشكله حتكون سنترال، يعني ما في اي دي اتش في الجسم من اول، يعني ما نقدر نقول نفروجينيك لانه حصل ريسبونس. تمام. طيب نرجع للكويشن الاخير. طيب هنا انا نشوف هذا الكويشن ايش اللي صار هنا بعد ما اعطينا الديزموبريسين. Nothing changed regarding lab values. يعني there is a problem in the kidney itself. So it's nephrogenic diabetes insipidus. So it's not peripheral. This is a typo. It's nephrogenic diabetes insipidus. Okay. Is it clear now? Okay, we have, let's just remove this. Okay. Right, we have a question about this question number 9. This is a direct question of Down syndrome that I have explained in the first slide. Let's go back to that. طيب هنا في الداون syndrome the common خلينا نقول الكومن كارديك ديفكت سميناها اندوكارديال كوشون ديفكت اللي هي اصلا يعني حتكون two things يعني atrial septal defect و ventricular septal defect at the same way. So we call it endocardial Cushon defect. هذه هي الايش؟ most common thing. My question was asking what is the most common يعني cardiac defect in Down syndrome. It is the endocardial Cushon defect. بعدها بيجي الباقيات. Okay, peripheral was nephrogenic, right? Yeah, it was a typo. The last question we meant by peripheral that it is nephrogenic. Yes, exactly. Do we have any other questions? Thank you very much. Please fill the form of attendance and the feedback. Thank you. Okay, we have here a comment. Can you repeat low dexamethasone test? Yes, I can. Let's get back to the slides. So the low dexamethasone test is one of the screening tests when we suspect the Cushing syndrome. Okay. What we do, we give 1 milligram of dexamethasone. طبعا dexamethasone one of the strongest glucocorticoids. طبعا what we are looking for احنا بعد ما نعطي الدexamethasone we are looking for a negative the response of the secretion of cortisol. إذا كان الشخص هذا normal, the secretion of cortisol will be low or will be inhibited because of the negative feedback loop. طيب بعد ما نعطيه على الساعة تقريبا 11 بالليل نشوفه الساعة 8 الصبح نعيد السيرم كورتيزول ليفلز. إذا ظلت increase يعني في عالية فكذا نقول إنه التست هذا positive. طيب and we suspect the Cushing syndrome and then we go on with our approach.